Hi, everybody. My name is Lynn Gerber, and I'm one of the current Regional Anesthesiology and Acute Pain Medicine Fellows at Stanford University. I'm very honored to have received a Best of Meeting award for the 45th Annual Regional Anesthesiology and Acute Pain Medicine meeting, and to have this opportunity to share our research with you virtually.
I'd like to share a randomized clinical trial performed by myself and colleagues at Stanford. I have no disclosures or conflicts of interest, and the learning objectives are shown. As one of the most common regional anesthesia techniques, the interscalene nerve block provides excellent intraoperative and postoperative pain control. However, it's also associated with a high rate of phrenic nerve blockade, which can lead to respiratory distress. We've previously reported subjective and objective improvement of diaphragmatic paralysis in patients receiving single-shot injections of normal saline into their interscalene space and through their nerve block catheters, suggesting that normal saline washouts may restore phrenic nerve function while preserving the nerve block's analgesic effect. In this randomized clinical trial, we aim to unveil a new technique of using normal saline to wash out local anesthetic from the interscalene space to restore phrenic nerve function while preserving analgesia, with our primary endpoints being diaphragmatic excursion as a surrogate for diaphragmatic paralysis and pain scores. Our secondary endpoints were brachial plexus motor and sensory function. Calculating the diaphragm's excursion ratio, as shown, allows us to see the degree of diaphragmatic movement and thus serves as an objective marker for diaphragm paralysis. As an example, here are ultrasound images demonstrating a dramatic example of diaphragmatic excursion with deep inspiration. The crosshairs demonstrate the location of measurements that we took during inspiration on the left and expiration on the right to calculate the diaphragmatic excursion ratio. Compare this to ultrasound images taken in the same patient 30 minutes after a bolus of ropivacaine via an indwelling interscalene nerve block catheter, which demonstrate an expected decrease in diaphragmatic thickening and thus excursion, consistent with paralysis. IRB approval, clinical trial registration, and patient consent were obtained. Study patients were randomized to either the control or the treatment group. And to be clinically relevant, we set the expectation that at minimum, 3 out of every 4 patients should have reversal of phrenic nerve blockade with normal saline washout. With a type 1 error rate of 0.05 and a power of 0.8, 8 patients per group were thus required to demonstrate clinical significance. In pre-op, after baseline measurements, patients received an interscalene nerve block catheter per the regional team's protocol and then underwent a general anesthetic for their shoulder surgery. In PACU, all patients received an additional local anesthetic bolus of ropivacaine 0.5%, 5 cc's, to reset the nerve block. We then randomized participants to either receive 3 doses of 10 cc's normal saline if they were in the treatment group, or 3 doses of a sham washout in the control group, and then took serial measurements of diaphragmatic excursion, pain scores, and brachial plexus motor and sensory exams. We found no clinically significant difference in reversal of diaphragmatic paralysis. All patients, regardless of group, remained with a paralyzed diaphragm, which was defined as a 25% or more decrease in excursion ratio compared with their pre-block baseline. However, in a sub-analysis stratifying the results by the degree of paralysis, there was a significant difference in the number of patients who ultimately displayed a partial paralysis, which is 25 to 75% decrease from baseline, versus a full paralysis, which represents a 75% or more decrease from their baseline diaphragmatic excursion ratio. This represents a difference in the degree of blockade between the two groups. In addition, there is no significant difference in participants' pain scores or PACU opioid requirement in either group. The secondary outcome measures also showed no difference in brachial plexus motor and sensory exams between the two groups at baseline, post-intervention, or when comparing individual change in exam scores. Perhaps why analgesia was preserved is due to the variable local anesthetic potency that varies with the rate of impulse traffic through each nerve. The high impulse traffic phrenic nerve is more readily blocked, but also perhaps more readily reversed with normal saline washout, as opposed to the lower impulse traffic brachial plexus. This randomized clinical trial shows that normal saline washout in 10 milliliter increments has no clinically beneficial effect on reversing phrenic nerve blockade. However, it may reduce the degree of blockade and also does not lead to a reduction in analgesic effect. In contrast to our and other experts' previous experience in successfully reversing phrenic blockade using larger volumes of normal saline, perhaps our intent of minimizing the potential rebound pain from the washout by using smaller incremental volumes was insufficient to unveil a clinically significant effect. However, more patients in the washout group did show an improvement from full to partial paralysis, suggesting that a larger bolus dose of normal saline may be sufficient to completely reverse diaphragmatic paralysis. Further investigations may use this as a dose-finding study in determining the minimum volume necessary of normal saline to produce a reversal of phrenic nerve blockade while preserving analgesia, similar to results seen in previous case reports. Here are my references. And last but not least, I'd like to thank my co-authors and contributors who helped make this possible. Please feel free to contact me at the email shown if you have questions or would like to further discuss this project. Thank you.